So let's just kick off from the top. Hello and welcome to the Medi-Cal Mobile Crisis Billing and Reimbursement Training, which is a DHCS funded project led by the Center for Applied Research Solutions, or CARS, that is dedicated to supporting California counties in implementing the Medi-Cal Mobile Crisis Benefit. One kind of quick disclaimer that we need to just provide is that this presentation was prepared by M-TAC under a cooperative agreement from DHCS. So while this event is supported by DHCS, the contents are those of the authors and don't necessarily represent the official views of DHCS or the US government. Again, just a warm welcome to everyone here today on what, maybe to some is not the most exciting topic, but certainly a critically important one, Medi-Cal mobile crisis billing and reimbursement. So sincerely, on the behalf of the whole M-TAC team, we really want to express an appreciation for your being here today. One additional note before we go over the learning objectives and the agenda is that neither Suzanne Rabideau, who is co-presenting with me today, nor myself have any relationship that would constitute a conflict of interest to this training. And do want to just make sure that we introduce ourselves. My name is Nicholas Williams. I'm here today with Suzanne Rabideau. We are both consultants with another firm, Health Management Associates, or HMA, and are helping to support CARS and the Department of Healthcare Services in the rollout of the new benefit. My background is really in policy and planning work for community-based organizations with a focus on behavioral health, and Suzanne has worked both at the state level on systems design and as a chief executive officer for a behavioral health provider specializing in crisis services. For today's agenda, we're going to be going over the following. First, what does DHCS define as a mobile crisis service, including the team composition and what activities constitute a response? Second, we're going to be going over the billing process itself for Medi-Cal mobile crisis services, as well as claiming for administrative services. And then finally, we're going to be doing a review of what the minimum requirements are that counties must meet prior to submitting a claim. And then we'll open it up for some questions. We're really focused today on two objectives. Number one, understanding what constitutes a mobile crisis services that can be billed and claimed under the Medi-Cal according to the BHIN, which I'm quite certain many of you are now familiar with, BHIN 23025. And then also understanding some of the codes and modifiers that will be used or can be used when billing for mobile crisis services. I want to just highlight for a moment the kind of piece in red there, that this training really is intended for folks who are highly versed in the California DHCS Medi-Cal billing manuals. The training really is an overview of what's allowable within the services themselves. So it's not a kind of how to exactly do the billing. It's kind of a bigger picture than that. So to that end, a few pieces that we want to make sure everyone here is aware of in this training, and so we're all on the same page, kind of about the vision for this new Medi-Cal mobile crisis benefit, and when that billing can occur, and the kinds of providers allowable. So the benefit that California is implementing as part of the mobile crisis is really just one piece of a new direction that California and other states really are taking to make mobile crisis services more responsive to community needs. The intent, based on best practices and research, is for the response to be resolution focused and to work to provide relief to people in crisis in the community, which evidence suggests leads to better outcomes. So key to that resolution is focused response to people in crisis, meeting them where they are, using the least restrictive means necessary to help them. So the new mobile crisis service or response services provided should be person-centered, trauma-informed, equity-driven, brief with a focus on intervention that seeks to de-escalate and resolve crisis. It works from a lens of least restrictive interventions, as I just mentioned, is culturally responsive, linguistically appropriate, and accessible. And so while this training isn't kind of part of the core requirements, it was really raised up as an important element as counties start to roll out the new benefit. So just a quick definition of mobile crisis. Mobile crisis services provide rapid response, individual assessment, and community-based stabilization to Medi-Cal members who are experiencing a behavioral health crisis. I kind of just went over the key tenets and principles of that. As part of the kind of what constitutes a mobile crisis team, there's a few different elements to it. Number one, at least 2 providers have to be available for the duration of the initial mobile crisis response. So that's really a critical part of this. It's a best practice for at least 2 providers to be physically present, but there is exception for some team members to participate via telehealth. Mobile crisis teams may provide services in this manner only if the Medi-Cal behavioral health system determines that that arrangement is necessary. And so that's language straight out of the behavioral health information notice on page 7. The mobile crisis team also has to meet these standards. At least 1 on-site mobile crisis team member has to be trained and able to administer naloxone. At least 1 on-site mobile crisis team member has to be able to conduct a crisis assessment. The mobile crisis team providing the initial mobile crisis response has to include or have access to a licensed practitioner of the healing arts as defined in the SUD treatment services or expanded SUD treatment services within the BHIN. Or a licensed mental health professional, including a licensed physician, licensed psychologist, licensed clinical social worker, licensed professional clinical counselor, licensed marriage and family therapist, registered nurse, licensed vocational nurse, or licensed psychiatric technician. And I think this is where I was going to turn it over to you, Suzanne.
Yes. Good morning to all of you. It's pretty impressive to see 164 people here attending. I think that's indicative of not only is it important to provide the service, but there has to be the operational components to actually bill for and receive the funding for providing the service. I'm going to transition a little bit to talking about the types of individuals that can be on a mobile team. I just want to remind us that our presentation is to help billing professionals know what are allowable codes and the modifiers, etc. But it's important to make sure that the requirements that are set out here are followed in order to do the billing. And so we just wanted to make sure we recapped that so that only billing is done when the requirements are met. And DHCS has allowed a variety of different providers to be on the mobile team. This is an image of the different kinds of providers. There's a couple of new provider types that are not always traditional on mobile teams. So like emergency medical technicians and paramedics, that's definitely a new endeavor, or also community health workers, and certainly certified peer workers can be on mobile teams. You can have any two of these individuals on the mobile team. So you could have two peer workers, two EMS, or an EMS and a peer worker. It can be all different kind of variations. The one piece is that there needs to be someone available to provide consultation that does fit the higher level licensure requirements. That's in the specifics of that are in the bin. So if we move to the next slide here, just again, what has to happen in order to constitute a mobile crisis in order to do the billing? So the activity of the mobile teams, they need to do a face-to-face contact that includes a crisis assessment, the actual mobile response, crisis planning as appropriate. So there's a training on doing crisis planning. So sometimes in the moment, it's not time to start doing how do we prevent a future crisis. But if it is appropriate and the person's open and willing to explore that, to prepare a crisis planning to avoid future crisis and then to document that. It is required to do follow-up check-ins with the individual that's received services. Now, we know that sometimes that there's not always the ability to contact a person, but there needs to be at least the outreach to try to make contact with the person, and then to document that in the record. And also, when appropriate, each mobile crisis encounter needs to also include referrals to ongoing services and to facilitation of warm handoffs. So the mobile crisis team shall be able to deliver all portions of this at any time, right? Knowing though that sometimes it may not be the right thing to do with that person at the moment, but the mobile team has to be prepared to do all of that. Okay. Service settings. With this enhanced benefit, new benefit, there's service settings that are allowable, and I'm going to cover in a minute the places that are not allowable. And this is important for the billing portion of this, right? It has to be in community settings. It's where the person is experiencing the crisis. And so these are some examples of community settings that the mobile team could go to, a person's wherever they're living, workplaces, public libraries, parks, schools, etc. It's going somewhere to assist the person and or family. On the flip side of that, there's service restrictions. And I want to just emphasize that this comes from the federal government, the laws that allowed states to move forward with this new benefit. And so it's the federal laws that are driving this. And they didn't want this to, they wanted it to be in the community. And so they specifically said there's some limitations on where you can use this because we want mobile teams to be going to the community. And so these are some examples of places that are not allowable. So going to an inpatient hospital, the emergency department, intermediate care facilities, all of these are if the mobile team goes to these places, you can't bill under this benefit. I also want to emphasize, though, that you all have other funding sources that you could be tapping into, or you have other ways of billing services. For example, many of you right now go to emergency departments to address someone that might be experiencing a crisis. However that process is happening for you, that's the way you continue to do that. But under this benefit, with the codes we're going to talk about, these settings are not allowable. Okay, one other important piece is that the federal government also allowed under this new benefit that in the event that a mobile team needs to transport someone somewhere, that is an allowable billable service. The way the state of California has set this up is there, and you'll see there's a you encounter for the mobile crisis intervention, response intervention assessment. But then on top of that, mobile teams can bill for the actual transportation. And we're going to get into the specifics about the codes as we move forward. But in the event that the mobile team transports someone, they can bill for that separate and apart from the mobile crisis encounter. We recognize that not everyone needs to be transported somewhere, right? Like it's you go out, you do an intervention, it's probably some small percentage of people that need to be transported. It's in those situations that the billing would be done. We also know that sometimes people, their lives are maybe, they're very, very, very distressed, and there may be a decision that's not safe for a mobile team to transport. In that case, the mobile team can arrange for other types of transportation to transport a person to, say, a walk-in crisis facility or some other kind of facility that the person needs to get supported at. We'll go into the codes here in just a few moments. Right now, we're going to go into the codes. Okay, just a little bit, I'm going to give you just a little bit more background on the federal government's role in rolling out this new benefit. So CMS has allowed states to implement this new benefit, and it's under resources that have come out of the American Rescue Act. And what happens is states are able to pull down 85% from the federal government for the service, and the state doing the match of 15%. And that's a much higher percentage than most states receive for the other services. With this requirement of allowable 85% to come from the feds, they implemented, and they said there's certain requirements that need to happen in order to do the billing under this 85%. And so many of the requirements that we just walked through have to be met in order to bill under this benefit. We're going to cover 3 topics. The mobile crisis encounter, how to bill for that, the transportation, how to bill for that, and also how to claim for administrative cost of operating the program. Okay, the mobile crisis service is an encounter-based rate, meaning all of the services provided by the mobile team is billed using one code with one unit, for one encounter. So all those services we just talked about, the assessment, the follow-up, all of those pieces, a crisis plan, all of that is included in the one encounter that will come in for each mobile response. Just to note that the rates are posted on this particular link, and you can access this link, and it's the typical place that you go look for rates. So you can look up the rates it's a rate by county, and so you can look that information up. Also, if you're interested in understanding how the rates were built, within the bin, there's some information saying, here's all the assumptions that were used in building these rates. Okay, now down to the detail, the codes. The specific code to use for mobile crisis encounter for Medi-Cal mobile crisis encounter is H2011, and you must use the place to service code 15. It says number 15 mobile unit. If it also, remember we said there's 2 people that have to go out, but if one person is remotely participating, you also have to use the modifier GT. And you only use that if it's applicable. Again, reminding you that the transportation code is an additional code on top of the mobile crisis encounter. All activity the mobile team does is done under the H2011. However, if they provide transportation, you also then use a transportation code. And so the staff time transporting the person is T2007. And then on top of that, you can also bill the transportation mileage under A0140. Okay. Now you're all familiar with the different manuals that are out there. The specialty mental health manual, we're going to go over that one first, and then we'll go over 2 others. So this is pulled straight out of Service Table 4, out of the manual. And here's the codes to use that I just went over. The allowable place of service, you always have to use place of service 15. And then it talks about things, are things locked out? Do you have to get a Medicare, COB, etc.? Look, it's all no. They're all no's on this. Maximum billing units that can be used is 24 or 96. I understand that the state may be doing some edits to this because you're not going to be doing 24 encounters in a day. So there may be some changes to this. I also just want to mention there's some asterisks down below here that indicate what you see on your screen is the most up-to-date information from DHCS. And like where you see this here, there is a if you looked in the manual right now, there's something different than what's on the screen, but this is the most up-to-date information. And also when you get, most of you know where to go find these, but there's also links to these manuals, both at the top of these slides and at the end of the slide presentation. Okay, the Drug Medi-Cal ODS billing manual. Pretty similar, right? It's H2011, the codes, you have to use the place of service 15. Exempt from Medicare COB. Yes, these are phrased a little bit different, but that's the same meaning. You don't have to have the Medicare COB. And then the final one, Drug Medi-Cal state billing. Again, it looks the same, pretty much. Those specific codes, you have to use the place of service 15, and there's no lockout, there's no requirement for Medicare. So let's just walk through this, and you can respond to this in your chat. And I do see questions in the Q&A, and I will, once we finish this, I will read through these and we'll provide some answers for you if we haven't already. So a mobile crisis team responds to a Medi-Cal member at a park. The team spent about 3 hours with the member. During this time, they arranged for her to go to a peer program the next day and coordinated her transportation to the program. Follow-up is conducted by calling the following evening. So what service would be billable and what service code would be used? If you could respond in chat. I need to get back to my chat. Very good. Thank you. Yep. Okay, we've got a couple of different answers here. Yes. That was someone already answered the next question. What would be the place of service? How would we bill for follow-up? Okay, so 15, correct. Would we also be billing for, I see A0140. I'm going to go back in my slides here. Would we be billing for transportation and mileage and staff time, T2007? Would we bill for this, yes or no? Aha, We got some yeses and some nos. Yes for the following day. Okay. In this example, the mobile team would not be billing for transportation because they're only arranging for transportation. That's part of the activity. They're coordinating care and getting people to where they need to go. So they're coordinating that for the next day. They're not providing transportation, so they would not be billing for transportation. They would be billing for the mobile crisis code using the place of service 15. And then their follow-up that they conduct the next day is included in that. So they're not billing for follow-up either. So just to recap, they are billing for mobile crisis using place of service 15. They are not billing for transportation in this example. If they had transported someone somewhere, they then would be billing for transportation.
Suzanne, can I make one quick suggestion before you get into the next part?
Yes.
I think we have a confluence of questions that maybe we can just pause now, answer those, and then kind of take on the second part.
Yes.
So there are some, maybe why don't you kind of take from the top in the Q&A box there, and I'll pull out the ones from the comments.
Okay, I just want to
Oh, sorry.
mention, from the chat, I'm seeing it's the word they arranged for. If this had said they provided her to go somewhere, then it would be billed. So the arrange for that activity of arranging is not a billable for transportation. That's part of coordination. So I just wanted to follow up on that. And I think people are saying, yes, I didn't see the word arranged. So, okay. I will go to the question and answer box. Are only certified peer allowed to be on the mobile team to make it a billable service? Yes, if you look in the BHIN, it talks about certified peers and what constitutes a certified peer. Okay, will DHS provide any further guidance on the requirements for the crisis assessment? Yes, that is going to be coming out, I would say within the next month. They did provide, they sent to counties draft versions of the crisis assessment. They send draft versions of 3 tools: the crisis assessment, crisis plan, and dispatch. So if every county received a version of that, and so you can look at that last version and get a good idea directionally of where things are going. That was a second round of feedback, and there was not significant amount of feedback like there was the first time. So we imagine these will not be wholesaled in any way, certainly tweaked and comments responded to. But if you look at those, you'll have a very good idea of where that's going. The next one, I'd like to verify that the location of homeless shelter is acceptable. That is a community-based service. Yes. Related to service setting restrictions, what does special treatment program consist of?
I'll say that I looked in the BHIN, and there is not a clear definition of that at this time. So I think that's something we can take back as an important question.
What is the definition of a specialized treatment program? Same question. Are there any limitations to bill the mobile crisis? The youth receives other mobile California mental health services on the same day. No, there are not restrictions around that. Because they may have gone in for therapy, things kind of get a little turned up, or they got some kind of home-based service, and then at the end of the day, now they're experiencing crisis and someone calls to get some help for them. That was an allowable service. maximum units per team, per client, per county. This is per client, per individual, not per team. The team can do multiple interventions a day. It's per client, an encounter per person. And I know that the numbers on that document create confusion around that, because it really shouldn't allow, you can't be doing 24 responses, and DHCS is going to be addressing that and cleaning up those numbers of allowable. You do one encounter per person. Sorry if I missed this. Are there multiple encounters for a single beneficiary of the course of one day? A team interacting with a person, and it happens to transcend over quite a bit of time, that is considered one encounter. We could take back to DHCS and ask them to get specific about what are the situations that when you would be encountering perhaps 2 encounters per person, what would the scenarios look like? So we can take that back. But the intention is there's an assumption that on average, there's so many hours that it takes to interact with a person. So, and sometimes the average means that sometimes it's longer, sometimes it's shorter. So there's built into this that some people take significant amount of time in intervention, and it's one encounter. But we will take back and ask about what would be a scenario of multiple encounters. Is there any guidance around the diagnosis should be used for mobile crisis encounters? Very good question. We will take that back. If a program has planned follow-up with a client related to the initial contact, are those services allowable to be billed or no? Follow-up to the crisis intervention and scheduled because of crisis intervention is part of the encounter. For example, they transport the client to that peer program the following day to support the initial crisis the day before. That example provides a little twist for me that I don't feel comfortable providing an exact answer on, and we'll come back. We'll bring that to DHCS, and they intend to be putting more Q&A responses together. Is there DHCS guidance about how we document the follow-up service and what code we use? Should we code it but put 0 minutes? It is not, you don't have to code and submit. You do have to document it in the record, and you would put their time in your record, but it's not an additional encounter. What is the DHCS definition of crisis encounter? We get all kinds of calls that come from the community, but when we arrive on scene, it's not a mental health crisis. Is that still billable if we go out to assess? You go out to assess, you've been called to a crisis, you're responding to it, you're doing, and your assessment is, this is not a very intense situation, or it's a billable encounter with a Medi-Cal member. One thing to think about too with crisis is if a person or someone else is feeling like something's very distressed, that's their experience of a crisis. You may get out there and see, oh, this situation is sometimes just time intervenes, and so by the time a mobile team arrives, and that can be even within a half hour, 45 minutes, things have calmed down, but you've responded, so it is a billable service. But you should still go through the process of documenting, what you've seen, what happened. That would be a good time to talk about future crisis planning. What can you do for the future to not get to the state you were what precipitated the situation previously, if it makes sense to have that conversation. But going back to the first part of this, what is the DHCS definition of a crisis encounter? It is the definition that we went over first that's in the bin, and it's doing those activities that are involved, which basically is doing an assessment. If you're getting out there and you're assessing the situation, that is an encounter. If you provide one client mobile crisis engagement 2 days in a row, how do you follow up sessions for the client? I'm not sure if the second day is the follow-up or you happen to go for a second intervention, like there was a second call for a mobile team to come out. You have to do follow-up no matter what. If you have an intervention, you have to do follow-up, attempt to do follow-up with that person. And so if you've called them, if they've called you a couple of days and you're planning to do follow-up, that follow-up would count towards either one of those two interventions or both. Our team routinely makes 2 to 4 follow-up calls. Would all of those calls be included under the original encounter? Yes. When a team responds to a crisis, which staff member would we use to bill? You're going to bill for the 2-person team. So you'd have one person making notes, documenting the intervention, and then you're pulling from that to submit. And it can be either one of the mobile team members that's doing the documentation. It's that documentation and then triggers that you can do an encounter. It doesn't matter which staff. What if the crisis team responds and is only able to speak with the family member because the client refuses to talk? Can we still bill? I want to go back and check with DHCS on that one. But again, in the same vein, you're going out to a situation, you are attempting to do an intervention. But let's go back to DHCS and make sure that they opine on the final answer for that question. Okay, second call and second referral. I think that's going back to the one I was talking about. You go out and do an intervention, and the next day there's a second call. Respond, you can do the second encounter, and then when you do follow up, it addresses both of those interventions. Does response time need to be included on the claim to prove the mobile crisis team responded under the billable response time? I need to check on that one. I believe the answer is you're just going to put 1 unit on there. But let me follow back up with that specific question. But I will tell you this is that you will separate and apart from claiming, and there's going to be some other guidance that comes out from DHCS about tracking other kinds of data that will come in other kinds of reporting. And I think that the time, like the response time, because I think that's what's being asked for here, that response time tracking does need to happen, but not for the claim, but on other kinds of reporting. Okay, are there other things that came into the chat, Nicholas, other than the Q&A? Oh, I think I have one more. Okay, i.e., if they take 2 hours to respond, we would document, but it would not be billable. You're allowed to bill for any service that you go out on, even if you go past the time, your time requirements. That is under another kind of compliance activity. And DHCS is working through a process and will come out with further clarification about the response time is a goal to be under, because the whole goal of this is to get to people in a timely manner. And so you need to have some parameters around. You need to get there in an hour, or you need to get there in 2 hours. That doesn't negate whether you can bill or not. But if you had consistent over 2 hours in an area that need to be in two hours, there would need to be a conversation about how are we going to get this response time down for a performance standard, but it is still a billable service. Okay, so would clinician bill for assessment and case manager for code 15? You have to have 2 people that fit the criteria of what we outlined on that prior slide, or really more what's in the bin. You have to have 2 people that fit those criteria in the bin, and you bill for that, the H code and the place of service 15, 1 encounter for the 2-person mobile team. Do both clinicians need to be reflected on 1 encounter claim, or does each clinician note separately with only 1 billable? There'll be one note on the person, can be written by either person, and then that's a billable service. You have to have 2 people doing the service, though. You don't need two entries. Okay, I think I get to the end and somebody else puts another one in. So this is good. Can a third party initiate the mobile crisis service? For example, a school staff, or yes. Anyone can call in to say someone needs help. You go and you go do your good work. And that is mobile crisis. And in fact, people are encouraged to be listening to other people that someone's in crisis, because the person in crisis themselves may not be aware they're in crisis, or be aware that they need help, or open, and they need someone to engage with them to know that receiving help is actually a good thing. And sometimes people need a conversation around that to do that. They would never call themselves. So particularly schools, law enforcement, all kinds of other referral sources are expected within crisis response, including the individual calling themselves. Okay, 2 more came in. What is the guidance when law enforcement is present due to a safety concern? Is the encounter still billable? Here's the frame of reference to think about this. In order to bill, you have to meet the criteria of having a 2-person mobile team and doing those activities. That's the criteria. If you have 2 people doing mobile intervention, it's billable, whether law enforcement is there or not. 2 people that meet that criteria. So a law enforcement could go out there first, make sure the place is safe, and then a mobile team comes behind, or a mobile team is there, and then they realize this situation is escalating and we need law enforcement to come in to ensure that there's safety in this situation. Law enforcement alone does not say whether it's billable or not. That's not the criteria. It's, is there a 2-person mobile team? And as long as you're meeting 2-person mobile team, it is a billable service. Now, there's this whole other activity of don't involve law enforcement when they're not needed, right? Only in these safety, when there's issues of safety. So it's not whether police are there or not, whether it's billable. It's, do you have a 2-person team that meets the criteria? And if so, you're good to go. Christina, I see your hand up. Perhaps it's related to what I'm talking about. Christina? Maybe Chris, Stephen, do we need to have her ask? Okay.
Thank you. Sorry, I couldn't unmute. Thanks. So question to that is, when you're saying that you need a 2-person that's part of the crisis team, would it also include if you have 1 person but another available via telehealth or via phone? Would
Yes.
that constitute?
Yes.
Okay.
But I just say, go and read the bin about what that constitutes. Like you can have one person by telehealth, but they have to be there the whole intervention.
Got it. Okay.
Yeah.
Thank you.
Yes.
Suzanne, I just want to flag that we have 12 minutes
Yes.
remaining, and I know we have a few more slides. So I just put in the chat that if folks could, if you kind of asked a question in the comments, put it in the Q&A. And if we don't get to it after we're kind of through the slides, we will make sure that we bring that back to DHCS, and it's kind of part of the FAQs that they're posting.
Okay, Nicholas, I think we'll, should we continue, or we've got to maybe?
I think we still have the administrative claiming slides to go through.
Yes, yes, very good.
So that's what
That's an important one. Yes. Okay, moving to the next slide here. Thank you, Nicholas. So just to recap, we will take any questions that's not answered and respond either with an answer on the M-TAC website, or we'll elevate the question to DHCS to provide a clarification. Okay, administrative claiming. So this is about administering the mobile crisis services. So the work that the county does to administer services, right? There's all kinds of things that you do. And these services are billable outside the encounter rate. And these are just some examples of things that might be done to administer the program. You need to coordinate and collaborate with community partners. Dispatch activities are outside of the encounter, completing data, collecting data, making reports, developing your implementation plan. All of those kinds of things are outside of delivering the crisis services. DHCS will be issuing additional guidance on how to administer, how to claim for these costs. And they're going to be issuing a bin that will be forthcoming very soon on how, and they'll include also the forms that you need to complete. Just one last comment to be sure that people are, that you need to, in order to start billing, you need to receive from DHCS an approval that you are good to move forward with your plan, and then you can start billing. So it's just one very important piece of the puzzle. You need to have your implementation plan submitted and have written approval to move forward in order to begin to bill. Let's move to, Nicholas, you want to take this slide?
Yeah, so just in summary here, mobile crisis services can be billed and claimed under the Medi-Cal when they meet those specific requirements of the BHIN, including the two-person team composition, that the services are community-based, that the services correspond with the activities that are outlined in the BHIN, and that the billing and claiming for Medi-Cal mobile services includes those specific codes and modifiers as outlined in the Medi-Cal billing manual. So long and short here, the BHIN and the Medi-Cal billing manuals are the key guidance, with the understanding that some of the billing manuals are set to be updated soon. So Suzanne, do you want to I'll take these last couple slides. Just in terms of resources, as just mentioned, the BHIN, there's the manuals are listed here. There's also the crisis resource needs calculator, which was used as a basis for coming up with the rates. And the last piece is another is the actual billing manual itself. But there's a whole host of resources, if you didn't know already, on the DHCS website. Here they are for you. And then we do have a few more minutes, Suzanne. If you want to tackle some more questions, let's do that.
Yeah. Okay. There was a question that you bill for the actual time spent, and the answer is no. You bill one encounter for the mobile crisis encounter, one, and then if you look at the rates, you'll see they're significantly higher than like a 15-minute increment. You get to bill one encounter per mobile response to an individual for that person for the entire time they're out there, and it's also included of the follow-up activity. So you don't keep doing for the actual time. It's one encounter. There's a question about what is the bin for criteria for providers. If you go into the bin, it lists out who can be on a mobile team. And it lists, your traditional like licensed and waivered individuals that you would think could be on a mobile team. It lists that, plus it lists other kinds of providers, certified peer workers, community health workers. It talks about what you have to do to be constitute a community health worker, and other kinds of emergency services. The number of the bin, okay, it's 23-025. And again, there'll be another bin coming out that clarifies about administrative claiming. Okay, perhaps I missed this information, but how to determine which delivery system the crisis service will be claimed in. At the very beginning of the bin, there's a paragraph or two that talks about creating an integrated approach for crisis response. So as a county, depending on how they're organized, right, they may have they may have different, both the specialty and the SUD, or they may have one. If you happen to have both, you can choose how you're going to do that, but it needs to appear to the community as one integrated system, like one number to call, and it's just you dispatch, you determine how you go. So you have some latitude on how you determine to organize. I do know that through a lot of other technical assistance, we've been hearing that those that do have separate, they're just choosing to do it through one arm, like say the specialty mental health, whether it's substance or person has, regardless of the person's experience or what's happening with them, if they have a substance use disorder or not, there's one entity and they're billing under that one specialty mental health, just to keep it simplified for themselves. So you have latitude on how you want to do that, but it needs to appear as a one integrated system to the community, and it's not going like this. You need to go here or you need to go there. And I do want to remind folks too that at any time you can ask for some one-on-one technical assistance from M-TAC. You can go onto their website and you can sit and you can walk through some of these very detailed questions that you may have to answer some of those questions for you specifically. Well, how if I do want to build from both, but I would need to have it come across as an integrated, what are the possible ways to get that done and do that? Or I do want to just do it one way. How do I make sure I'm staying in the lane I need to stay into to make sure I'm crossing my T's and dotting my I's? So please do reach out for that individual technical assistance for more detail for your county. What if you respond to a non-Medi-Cal client? That's a very good question. We're talking here about the Medi-Cal benefit. The county, each county has to go through a process of, do we have resources to respond to non-Medi-Cal members? and how do we start having those resources pulled together? And I do know, aside from the work that DHCS is doing to roll out this Medi-Cal benefit, there is conversation across the state and processes to explore how do we have a fully integrated continuum of crisis care that addresses the need for all Californians. And there's going to be information coming out about a stakeholder process to get involved in to answer those kinds of questions. But what we talked about today was specifically for the Medi-Cal benefit. If we have call outs and we only have one clinician, we cannot bill for that service. If you have one clinician, that is then not a billable service. However, keep in mind your ability to bill under this code with the place of service 15, you have to meet these requirements. But there may be other ways that you can bill for services that are not this code. So you might do crisis intervention without using the 15, how you may have used that in the past, whatever ways you use to bill Medi-Cal in the past for community-based services, you could still use. If you do this H2011 with modifier 15, you have to meet those requirements. So it's not a end all be all. You have to get a little creative on the other end, but we want to move the system to having 2-person mobile teams. But that scenario of sometimes you have call outs and sometimes it doesn't meet the bill of the requirement. And so you need to do some alternative means and respond to people, right? To take care of people.
Thank you, everybody, for your time today. Really appreciate you and all the work that you do.
Thank you. Bye-bye.